Welcome to the deep dive. This is where we take your source material, really dig into it, and pull out the essential stuff you need. Think of it as your shortcut to getting up to speed fast.
Exactly. And today the focus is squarely on you,
Like
especially
it.
if you're a nursing student gearing up for the NCLEX-RN or heading into clinicals.
Yeah, this deep dive is specifically for you. We're looking at a drug you are definitely going to encounter a lot.
We really are. We're using a source titled Furosemide, a Luke diuretic compendium. It's packed with the critical info you need. This medication, it's fundamental.
Absolutely. So our mission today is to extract the absolute must-knows about furosemide. You probably know it as Lasix straight from this compendium. We'll focus on how it works, the risks, and importantly, your role as the nurse.
It's super common, really powerful, so understanding it inside and out is key. Let's just dive right in. What is furosemide? What's it doing in the body?
Okay, so this source classifies it as a loop diuretic. That name itself kind of gives you a clue about where it works, right?
Mm-hmm. It acts in the kidney, specifically in the loop of Henle, and also the distal renal tubule.
And its core action, according to the compendium, is inhibiting the reabsorption of sodium and chloride there. So it stops the kidney from pulling those electrolytes back in.
Right. It blocks that process and the result of that blockage.
Well, increased excretion, you end up losing more water, but also sodium, chloride, magnesium, potassium, and calcium. It really pushes fluids and electrolytes out.
And a really important point the source makes is that furosemide still works pretty well, even if a patient's kidney function isn't great. That makes it super useful in certain situations.
Okay, so it makes you pee out a lot of water and salts. What's the therapeutic goal then? What are we trying to achieve?
The main effect is diuresis, getting rid of that excess fluid. Think edema, that swelling you see, or pleural effusions, the fluid around the lungs, helps mobilize all that.
And less fluid volume means.
Lower blood pressure, that's the other major therapeutic effect listed.
Got it. Diuresis and lower BP. So who are the patients getting this? What are the main indications?
The source says for oral, IM, or IV use, it's for edema caused by heart failure, liver problems, hepatic impairment, or renal disease.
And there's also a subcutaneous route.
Yeah, the SUBQ route is mentioned specifically for edema due to chronic heart failure.
Okay. And just for high blood pressure, hypertension, the oral route is indicated. So fluid overload and hypertension seem to be the big ones.
Exactly. Now, timing is everything with this drug, clinically speaking. Let's talk pharmacokinetics, the time action profile.
Right. The source mentions absorption varies. Oral is like 67%. IV is, well, complete absorption, obviously. And SEBQ is actually really high, 99.6%.
Its half-life is pretty short, maybe 30 to 120 minutes, but remember, that gets longer if the kidneys aren't working well.
And this time action profile is crucial for you to know. For the diuretic effect, PO or oral starts in about 30-60 minutes, peaks in 1-2 hours, and lasts around 6-8 hours.
IM's a bit quicker, 10-30 minutes onset.
But fire, super fast. Onset in 5 minutes, peaks in 30 minutes, but the duration is much shorter, only about 2 hours.
And the SUBQ route, the source says it lasts 8 hours, but it doesn't actually specify the onset or peak time.
So that rapid IV onset is why it's used in acute situations, right? But that short duration means you're already thinking about the next dose or maybe a continuous infusion.
Exactly. While the PO route lasts longer, making it better for maintenance, knowing these times helps you anticipate, when your patient's going to need help getting to the bathroom, probably often.
Definitely. Okay, so it's powerful, but who should not get furosemide or who needs extra caution? What about contraindications?
The absolute contraindications from the compendium are hypersensitivity to furosemide itself. And really watch out for potential cross-sensitivity with thiazide diuretics and sulfonamides. That's a key nursing check.
Foot allergy, yeah. Good
Yes.
point. What else?
Hepatic coma is a no-go, and anuria if the patient isn't making any urine.
Makes sense. You can't force urine out if none is being made.
Right, and the SUBQ route specifically adds hepatic cirrhosis as a contraindication. Oh, and some liquid forms might have alcohol, so check for alcohol intolerance.
Okay, precautions. Who needs careful watching?
Patients with severe liver issues, because furosemide could actually tip them into hepatic coma. Anyone already low on electrolytes, you don't want to deplete them further.
What about diabetes?
Good question. Use with caution in diabetes mellitus because it can raise blood sugar levels.
And you mentioned something earlier about ototoxicity risk.
Yes, the source highlights that patients with low protein levels, hypoproteinemia, or severe kidney impairment have an increased risk of hearing damage. Ototoxicity, we need to talk more about that.
Okay, we will. What about specific populations? Pregnancy, kids, older adults?
Pregnancy and lactation is a risk-benefit calculation. For kids, especially preemies, the source notes a higher risk of kidney stones and a heart issue called patent ductus arteriosus.
And older adults, always a concern.
Definitely. It's on the Beers list for potentially inappropriate use in older adults. They have a higher risk for hyponatremia, low sodium, and related falls. The source really stresses close sodium monitoring for them.
Okay, lots to watch for. Let's dive into those side effects, the adverse reactions. The compendium lists a whole bunch, but what are the absolute must-knows for nurses?
Right. You might see things like low blood pressure, maybe some GI upset, rashes, high blood sugar.
Hmm.
But the two major ones you absolutely need to have on your radar are electrolyte imbalances, especially hypokalemia, and that ototoxicity risk.
Let's tackle hypokalemia first. Low potassium. The source lists it clearly. Why is it so common with furosemide?
It goes back to the mechanism. It directly causes the kidneys to excrete more potassium along with the sodium and water. It just gets flushed out.
So what signs and symptoms of low potassium should you be looking for in your patient? What does the source say?
Be alert for muscle cramps, muscle weakness, feeling nauseous or dizzy, maybe numbness or tingling in their hands or feet. Those are definite red flags.
And clinically, why is this low potassium such a big deal? What are the dangers?
The compendium flags two huge risks. First, a significantly increased risk of digoxin toxicity if the patient is also taking digoxin.
Ah, that classic interaction.
Exactly. And second, an increased risk of dangerous heart rhythms, arrhythmias, especially if they're on other meds that affect the heart's electrical cycle, the QT interval stuff. So that furosemide plus digoxin combo, you have to monitor that potassium like a hawk.
Got it. Hypokalemia, common, know the symptoms, major risk with digoxin. What's the other big one you mentioned?
Ototoxicity, hearing loss. It can also cause tinnitus, that ringing in the ears.
And when is that risk at the highest?
According to the source, the risk goes way up with rapid IV pushes or really high IV doses. Also, higher in patients with poor kidney function, or if they're getting other ototoxic drugs at the same time, like certain antibiotics, aminoglycosides, or chemo drugs like cisplatin.
Low protein levels too, right? You mentioned that increases the risk.
Yes, hypoproteinemia also bumps up the risk. So pushing that IV furosemide too fast, especially in someone with kidney problems, you could potentially cause hearing damage.
And the source even recommends hearing tests, audiometry, for patients on long-term high-dose IV therapy. That really underscores the seriousness. Unlike electrolytes, which you can often correct, hearing loss might be permanent.
That's the critical point. So proper IV administration rate is non-negotiable.
Okay. Besides those two big ones, what else should we briefly mention?
Well, obviously, hypotension, dehydration from losing too much fluid, other electrolyte issues like low sodium, hyponatremia, low chloride, low magnesium, low calcium, which can lead to metabolic alkalosis.
What about skin reactions?
Yes, the source lists some very serious ones. Stevens-Johnson syndrome, SJS, toxic epidermal necrolysis, TNN, erythema multiforme. The absolute key nursing action here: stop the drug immediately if you see any kind of rash developing and notify the provider.
Don't wait on that one.
Definitely not. Also, photosensitivity, they'll be more sensitive to the sun. And don't forget hyperglycemia, that high blood sugar, and hyperuricemia, high uric acid, which could trigger a gout attack.
Wow, okay. So this naturally leads into drug interactions. What does the compendium say furosemide interacts with?
Lots of potential interactions. You've got an increased risk of low blood pressure if it's given with other antihypertensives, nitrates, or even just acute alcohol intake.
And the risk of hypokalemia goes up if given with
other diuretics, amphotericin B, stimulant laxatives, corticosteroids. It just highlights why you need that full medication list.
And hammering that point home again, the hypokalemia caused by furosemide makes digoxin toxicity much more likely.
And increases arrhythmia risk with those QT prolonging drugs. It also messes with lithium. It decreases lithium excretion, so lithium levels can become toxic.
What about the ototoxicity risk with other drugs?
Increased risk when combined with aminoglycoside antibiotics or cisplatin.
Can anything make furosemide less effective?
Yes. NSAIDs, think ibuprofen, naproxen, also sucralfate, clostridium, cholestyramine can decrease its effects.
Anything else?
Increased toxicity risk with methotrexate and high-dose salicylates like aspirin, and increased risk of gouty arthritis if taken with cyclosporine. It's a busy drug, interaction-wise. Really emphasizes the nurse's role in med reconciliation.
Absolutely. Which brings us right to the core nursing care described in the source: assessment, implementation, and teaching.
Assessment is just critical. You have got to monitor their fluid status super closely. That means daily weights, same time, Same scale, same clothes if possible, accurate intake and output.
Assessing edema, where is it, how much? Listening to lung sounds for crackles, checking skin turgor, looking at mucous membranes for dryness.
And know those signs of dehydration to report. Thirst, dry mouth, feeling weak or lethargic, low blood pressure, decreased urine output.
Monitor BP and heart rate consistently, especially before, during, and after giving a dose, particularly IV.
And for older adults, always do that falls risk assessment and put precautions in place. They're more vulnerable to dizziness from fluid shifts or low BP.
And let's circle back to that digoxin connection. The source emphasizes assessing for digoxin toxicity symptoms. Loss of appetite, nausea, vomiting, muscle cramps, that weird tingling or numbness, confusion.
Right, and remember, they might be on potassium supplements or a potassium-sparing diuretic alongside the furosemide, specifically to prevent that hypokalemia.
Also, assessing for tinnitus or hearing changes, especially in those high-risk groups or with high IV doses. The source mentions considering audiometry for prolonged high-dose 5E.
Don't forget screening for that sulfonamide allergy before giving the first dose.
And skin checks. Assess for rash frequently. The compendium is really clear. Stop it at the first sign because of that SJS-10 risk.
Lab monitoring is huge. You need to be checking electrolytes, especially potassium, before and periodically during therapy. Also, kidney function, BUN creatinine, liver function tests, blood glucose, and uric acid levels.
And you need to anticipate the expected changes, right? You expect potassium, sodium, calcium, magnesium to potentially decrease.
Correct. And you might see BUN, creatinine, glucose, uric acid, and liver enzymes increase. Knowing the trends is key.
Okay, let's talk implementation, actually giving the drug safely. First off, basic safety.
Yeah.
Double check the name, Lasix, not Wakix, or anything else that sounds similar.
Good point. For timing, if it's ordered twice a day, the source suggests giving that last dose by 5 p.m. You don't want them up all night having to pee.
Makes sense if giving it parenterally.
5E is usually preferred over IM if possible. Orally, you can give it with food or milk if it upsets their stomach. Tablets can usually be crushed, but always check first, and don't use discolored solutions or tablets.
Okay, IV administration needs special care because of the ototoxicity risk. What are the rates?
For IV push in adults, the source says no faster than 20 milligrams per minute. For kids, it's slower, max 1.5 to 1 milligram per kilogram per minute, and not exceeding 10 minutes total push time.
And for intermittent infusion, like a piggyback?
You'll need to dilute it according to pharmacy or drug guide instructions. It's usually stable for 24 hours, protect it from light, don't refrigerate. The rate is critical for larger doses. In adults, if the dose is over 120 milligrams, infuse it slowly, maximum 4 milligrams per minute, again, to prevent ototoxicity.
So a 160 milligram dose would need to infuse over at least 40 minutes.
Exactly. For kids, the max intermittent infusion rate is 1 milligram per kilogram per minute, not exceeding 10 minutes. Always use an infusion pump for accuracy and safety.
And why site compatibility?
Always check your compatibility resources.
Sure.
The source lists some common ones, like it's okay with D5W, but it's incompatible with others, like diazepam. Don't guess, look it up.
What about that SUBQ route with the special device?
Right, the infuser device for chronic heart failure edema. It's pre-programmed by pharmacy, usually. You'll take patient site rotation on the abdomen, keeping it away from the beltline. You need to limit activities somewhat, keep the device dry, away from electronics. And understand it's usually temporary, aiming to get back to oral meds.
Okay, finally, patient and family teaching. This is so important for them to manage safely at home.
Absolutely critical. Explain why they're taking it, the potential side effects. Stress taking it exactly as prescribed, and what to do if they miss a dose, basically. Take it as soon as remembered, unless it's almost time for the next dose, but never double up.
Emphasize keeping follow-up appointments for lab checks and monitoring.
Make sure they tell all their healthcare providers, doctors, dentists, pharmacists, that they're taking furosemide, especially before any surgery or procedure.
Caution about orthostatic hypotension. Teach them to change positions slowly, sit on the edge of the bed before standing, that kind of thing. And avoid things that make it worse, like alcohol, hot weather, standing still for long periods.
And the source specifically mentions instructing the patient to consult their healthcare professional about increasing dietary potassium. They might need guidance on potassium-rich foods.
Tell them to report any sudden weight gain the guideline mentioned is often more than 3 pounds in one day. That signals fluid retention.
Warn about photosensitivity. Use sunscreen. Wear protective clothing when out in the sun.
And this is crucial. Teach them the red flag symptoms to report immediately. What does the source emphasize here?
Call right away for any rash, muscle weakness, or cramps, reminding them this could be low potassium nausea, dizziness, or any numbness or tingling. Those need prompt attention.
Good. What else for teaching?
If they have diabetes, stress the need for closer blood sugar monitoring. For women, discuss pregnancy and breastfeeding intentions and the need to notify their provider. The source mentions monitoring fetal growth if used during pregnancy.
For older adults, really reinforce those fall prevention strategies at home.
And for hypertension patients, teach them furosemide helps control it, it doesn't cure it, they need to keep taking it even if they feel fine. And reinforce all those important lifestyle changes: diet, exercise, sodium restriction, stress management.
Effective teaching really empowers the patient. It's a huge part of nursing care.
It really is.
So, after all this, the assessment, giving the med, teaching the patient, how do we know if furosemide is actually doing its job? What are the desired outcomes according to the compendium?
Pretty straightforward, actually. You're looking for effective diuresis, increased urine output, leading to mobilization of that excess fluid. So decreased edema, clearer lung sounds, maybe decreased shortness of breath,
And the other goal?
a decrease in blood pressure,
Yeah.
if that was one of the indications. Seeing those improvements tells you the drug is working therapeutically.
Okay, we have covered a massive amount of ground. Furosemide's mechanism, why it's used, those really critical risks like hypokalemia and ototoxicity, the interactions, and all the essential nursing care points pulled straight from this compendium.
Mastering this information is absolutely vital for doing well in the NCLEX-RN and, way more importantly, for keeping your patients safe in clinical practice.
Understanding these specifics like the IV push rates, the red flag symptoms, the digoxin interaction, that gives you the confidence you need to manage patients on this very, very common drug. So let's leave you with a final thought to chew on based on everything we've discussed from the source. Furosemide is powerful, right? It pulls off a lot of fluid, but it also carries these significant risks: electrolyte depletion, potential hearing damage. So how do you, as the nurse, strike that balance? How do you achieve the necessary fluid removal while constantly monitoring to prevent serious harm? What does that vigilance look like shift to shift? Something to really think about.
This deep dive into furosemide is part of the Book of Podcasters Drug of the Week series.
And we will be back next week digging into another essential medication. If this breakdown was helpful for you, please hit that like button and subscribe so you don't miss the next one. Thanks for joining us.